Welcome to Your Practice, Your Money, the podcast where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos, and in every episode, we bring you actionable insights to grow a thriving and profitable healthcare practice. Are you charging what you are worth? Are you attracting and keeping the right patients? And could perhaps diagnostic testing be your next major revenue stream? And is your practice truly set up to work for you, not the other way around? Well, if you are a physical therapist, a physician, a chiropractor, a podiatrist, or any type of healthcare entrepreneur, this show is your roadmap to next level success. So let's dive in.
Thank you all for joining me today. I am delighted to discuss a very interesting topic, especially for the profession of physical therapy. Today, I will be sharing some ideas and viewpoints about physical therapy as a primary care profession and what is the role of EMG and MSK ultrasound testing within that spectrum of physical therapy as a primary care profession. So, first of all, I'm Dr. Dimitrios Kostopoulos. I'm the chairman of the board of Hands-On Diagnostics and the Hands-On companies. And I have many years of experience as a physical therapist, as a board-certified clinical electrophysiologist, and as faculty member and co-founder of the Hands-On organization. So thinking about physical therapy as a primary care profession, the question somebody has to ask is, okay, what is a primary care profession? What makes a profession primary care? A primary care is a profession that becomes the first point of contact within that healthcare system. And traditionally, that applies to general practitioners, internists, family physicians, doctors who treat peds, and also OBGYNs. Okay, so traditionally, this is the type of professionals who have been defined as primary care professionals. Okay. Now, the focus of that profession is not just looking one specific disease, but looking at the person as a whole. And it includes not only patient evaluation, but also the ability to identify the cause of the patient's problem by the performance, by identification of a diagnosis. In physical therapy, it would be physical therapy diagnosis. And then to look also at patient education and prevention of future similar dysfunctions. How about the physical therapy and the physical therapist as a primary care professional? First of all, physical therapists are very well positioned because of their education, their background, the type of relationships they create with patients, and also the effects that they can have in many neuromusculoskeletal problems that patients have. They are regarded as very well suited and positioned to be primary care professionals. So this is not a new idea. It has been around for many years, and even ABTA's House of Delegates has put quite a bit of focus in the area and has explored ways to position the physical therapist within the primary care delivery system. Even organizations, the US military, and even Kaiser Permanente, they have incorporated concepts of direct access and the visibility, the positioning of the physical therapist as a primary care provider within the team of experts. If we go back to the definition of a primary care profession, what are these components that can make the physical therapist really that primary care provider? Because if we look at the future and the opportunities that exist for physical therapy as a profession, as a whole profession, the opportunities for truly positioning the physical therapist as a primary care professional for neuromusculoskeletal disorders is very, very real. So the first thing that the physical therapist can be is for the physical therapist to be the first point of contact. So simply, if within the society, we communicate the message that for neuromusculoskeletal related problems, you go right away to a physical therapist without having seen a medical doctor before, that can then become very real, that we're going to be seeing more and more patients as their first point of contact. Now, then, that patient must not just receive a simple evaluation, but it has to be a comprehensive evaluation to look at all different aspects of that patient's dysfunction, that patient's current problem, and overall health. And nowadays, physical therapists are very well trained, especially through the DPT or transitional DPT programs, very well trained to evaluate all different systems of a patient and even make the appropriate referrals when needed. But these evaluations must also include advanced diagnostic testing. So let's think about this for a moment. If you have a primary care physician, it's a primary care physician, a family physician, so that family physician will be viewed as the primary care first point of contact for the other non-musculoskeletal type of problems that the patient has. So if somebody feels they may have hypertension, they may have high cholesterol, they may feel an internal type of pain, indigestion, or any other type of discomfort that is not obvious neuromusculoskeletal in nature, then that person is going to visit a family physician, a internist, a general practitioner. And that general practitioner will not only perform a physical examination to that patient, but he or she will also perform some related diagnostic tests. For example, they are going to take the patient's blood pressure. They are going to send the patient for blood work so they can look at their cholesterol, their liver enzyme, their CBC, and their sugar levels. So in the physical therapy area, when looking at the physical therapist as a primary care provider, we have to look at what is this advanced testing that the physical therapist can provide to accurately and precisely identify the root cause of the patient's problem in a comprehensive evaluation, and then come up with a proper patient management. The parallel to a internist or family physician or a general practitioner to what a physical therapist will do in addition to their regular physical therapy, physical examination that can include advanced diagnostic testing such as musculoskeletal ultrasound, electromyography and nerve conduction testing, evoked potential testing, and vestibular testing such as VNG, video nystagmography for vestibular dysfunction, which are tests that the physical therapist can perform and can get paid also by insurances for performing them. The third component of the physical therapist as a primary care professional is a patient-centered care. So the physical therapist develops an individualized, tailored to the uniqueness of that patient management program. Number 4 is longitudinal management, where the physical therapist will adjust treatment strategies based on the patient's progress and any changes in their health status. Of course, collaboration with other healthcare providers and referral to them of patients who need to be referred out. And of course, health promotion and prevention, playing a role in specifically advising patients on how they can prevent future similar problems. In recent years, physical therapists have incorporated in their practices advanced diagnostic tools. Some of these models started from the US military, where I told you that physical therapists are regarded as primary care professionals. And in many instances, they are able to refer and or perform tests that now, for the past several years, a couple of decades now, physical therapists in the public, they are able to perform. And these, as I said, are electromyography, musculoskeletal ultrasound, evoked potential studies, and video nystagmography. So as primary care providers, the use of these diagnostic tests by the physical therapist allows them to provide a higher level of care to their patients and being able to align with the aim of primary care, which is to optimize health and wellness for the patients. Let's look for a moment one of the clinical challenges we have as physical therapists when we simply perform a physical examination utilizing maybe some of the special orthopedic or neurologic tests to identify pathology. And the challenge is that some of these physical examination tests, they have very low sensitivity, leading to many false negatives. So, what do we use for carpal tunnel? Tinels and Fallens, right? Look at the sensitivity of the testing. 23% for Tinels, 51% for Fallens. Just imagine if you were doing, let me use a COVID screening, right? And you did a COVID test and the possibility for getting it right was 23% sensitivity. That would not be necessarily good test to be applied by itself. Thank God, those tests had a much greater sensitivity. But as you can see here, even in other conditions like cervical radiculopathy, Spurling's test has a sensitivity of only 30%. In many cases, implementing just a physical examination test will not be totally enough to give us the total picture about the patient. Instead, if we incorporated some of these advanced diagnostic procedures, such as EMG studies or MSK ultrasound, that sensitivity can jump from 23 to 86%. Or you can see here for cervical radiculopathy from 30% Spurling's test to 71%. So we're talking about very significant differences. Look at in a rotator cuff test, both Hawkins and Near test, they have a 79% sensitivity, which is pretty good. but musculoskeletal ultrasound enjoys a 92% sensitivity, which is very important and very, very different than not doing them. So in a study that was published in 2020 at the Journal of Bodywork and Movement Therapies, the study was done on over 465 patients, multi-center study. And the study identified that in 61% of the patients, the patient management changed because of the results of EMG testing. A similar pilot study for ultrasound yielded very similar results. And not only that, but more than 90% of the patients agreed that they were better able to understand and manage their problem because of the results they found out from their EMG test. Now, looking at the current model of physical therapy, where we have a physical therapy evaluation, treatment plan, treatment intervention, reevaluation and continuation of physical therapy and end of care, from a business point of view, that provides a limitation in the universe of CPT codes that we use for physical therapy, a limitation in terms of capitations, time limited codes, and so on and so forth. But the incorporation of diagnostic testing at some point between the evaluation of a patient, the initial evaluation, and the creation of a finalized treatment plan can yield much better clinical outcomes and creation of much more appropriate treatment plans for that patient. And of course, as an additional benefit is that it provides a more than 30% increase in the total revenue you're getting for that session. Look at the example where you have this patient, where you are examining a range of motion versus being able to look inside that shoulder and evaluate the structures in that shoulder, inside that joint, okay? And being able to make conclusions about that. So what about if you were able to see inside the body? And you can do that. I'll give you some examples, right? So this is a shoulder pain patient, 50-year-old construction worker, progressively increasing right shoulder pain over a 6-month history. Now, here is the interesting thing. The patient was denied the MRI and it was given a referral for physical therapy. Now, let's look at this for a moment. So you have an injury that takes place, chronic or acute. The patient seeks medical attention. Usually, in a case like a shoulder, they're going to send the patient for an MRI. The MRI will be denied. And it will be denied because they want the patient to have 3-4 weeks of physical therapy with no result for them to approve the MRI. So essentially, what the insurance company wants to have a failed physical therapy before they approve that MRI. So meanwhile, when you give the initial failed PT visits, you consume 3-4 weeks of the patient's life, 10 out of their 20 allotted visits for the calendar year. And then if the patient requires post-op PT, then you have 10 sessions left. All right? So this does not sound right. This is not well-thought healthcare. Instead, what if we performed point-of-care musculoskeletal ultrasound at the first point of contact, the physical therapist? So in that case, as a physical therapist, you would be trained to compare a normal musculoskeletal ultrasound with an abnormal musculoskeletal ultrasound that clearly shows you that the patient has a supraspinatus complete tear. And you, at your office, at your clinic, you're able to perform this test and identify this result. So then what do? Would you keep this patient with complete supraspinatus tear? Well, you're going to send the patient to an orthopedist. You're going to get surgery, as this patient had, and then physical therapy will start right after the surgery. The patient will have almost intact all of their PT visits, and the patient would be happy, and the orthopedist would be happier. So they got to see and help this patient right early on. Let's look at another patient, another case here with a patient that was playing CrossFit and would feel pain in the dorsum of the left wrist. Now, this patient saw another physical therapist for 6 weeks. Now, that physical therapist performed 6 weeks of failed physical therapy, unresolved physical therapy, and that patient went finally to a physical therapy place that performed, thankfully, diagnostic studies. So what was identified? That this patient had the ganglion cyst in the dorsum of their left wrist. What would you do with physical therapy with that patient? The patient was splinted. Instead of doing more and more strengthening exercises and ultrasound and electrical stimulation and paraffin baths, then was referred to ortho. The surgeon performed a procedure of aspiration, and then the patient followed with PT. Happy patient, happy doctor, happy everybody. And finally, let me show you a case of a patient with numbness and tingling in both of their hands. And that patient was referred for electrodiagnostic testing only, after they had received 4 weeks of physical therapy in the office of the physician who ended up referring the patient for electrodiagnostic studies to that PT practice. Well, an EMG demonstrated that the patient had a carpal tunnel syndrome and a superimposed cervical radiculopathy on the C7 nerve root. So now, what did the physical therapist do with all this data? Well, the physical therapist, who was properly trained on this, because the patient had a right carpal tunnel syndrome that involved not only the myelin, but also the axons, performed neuromobilization techniques of slider gliders and no tensioners, because tensioners would have made the axonal pathology even worse. And also, for the cervical radiculopathy, perform mobilization manipulation specific to the segment involved, because the therapist knew what was specifically wrong with that segment of the patient. Now, everybody was happy about this, and the patient full recovery. Now, on the front of the finances, physical therapists have been really affected with significant reductions in reimbursement. And in 2022, actually, profit margins for physical therapists were even less than 10%. 2022 data from the KPI study of PPS-APTA demonstrated profit margins somewhere 7.5% to 8%. So that is a big problem. So you can see here that study of PPS-APTA and the KPI study data. You can see the median profit margin of physical therapy private practices was 7.2%. 7.2% is very, very unsafe profit margin for a practice to be. Medicare gets a hiccup, United Healthcare sneezes, and you are in big trouble with these numbers. And unfortunately, we see that despite the fact the median profit margins for 18, 19, and 21 were around 12.5%, in 2022 significantly dropped. And the first quarter of 23 actually does not have much more encouraging numbers because of all of the reductions we have seen in the physical therapy industry, and also the tremendous expenses in payrolls because of lack of PTs. However, what I'm showing you here is the type of profit margins we have been enjoying in our physical therapy practice. And you can see that since 1999 that we implemented diagnostic testing in our practices, we are enjoying profit margins greater than 20, 25, up to 30%. And improved patient care, to say the least. This happens because diagnostic testing has a very different range of reimbursement. 1 hour of physical therapy, national average, is about $97. For 1 hour of EMG and a neuro-ultrasound combination, it is $700. So that is very significant. And it is not only our practice that enjoys that. Other practices who have received this training, they have been able to enjoy significant increases in their reimbursement rates, from 25 to 47% increases, which is huge. My friend Bart McDonald from Superior Physical Therapy, before he started his training with hands-on diagnostics, he had 4 locations and he was making $104 per session. After HODS, he did not have to increase the number of locations he had because he increased significantly the revenue he was making by almost 32% with the same exact locations, the same exact patients. No additional headaches, no additional locations, no additional marketing. Just with what you have, you can increase significantly your revenues. The practices of Christina Panetta, she went up to a 39% increase, offering the musculoskeletal ultrasound and electromyography and nerve conduction study services in her practice. Northern Physical Therapy up in upstate New York, still there are 3 locations, but they increased their revenues by almost 37%, with significant revenues within 12 months from the moment they started our program, close to $800,000 just from diagnostic testing. So these are the successes of some practices that get involved with hands-on diagnostics. And what hands-on diagnostics does, it creates an approved diagnostic center for you. And this center runs in parallel with your physical therapy practice. So within your existing location, you are able to run an approved diagnostic center. And there are several accreditations that we help you to achieve in that diagnostic center. And you have, of course, a territory of exclusivity. That area is exclusive to you and to the expansion of your practice. And I'm going to show you a little video in terms of how we as an organization help these practices to market the diagnostic testing services they offer along with their physical therapy services.
What if there was a way to see inside your body, pinpoint the source of your pain, and speed up recovery time? Now you can with diagnostic testing and physical therapy. Advanced nerve testing and muscle ultrasound testing allow your physical therapist to quickly and accurately find the true source of your pain. No more wasting time to see if treatment works. No more guesswork. Your physical therapist will see your problem in real time and create a treatment plan that is proven to be 62% more effective than standard physical therapy. Ask your physical therapist if they offer this cutting-edge service or locate an approved diagnostic center near you at findbestpt.com.
So you can see some of the assistance and help we provide to those facilities that work with us, both on them becoming educated on the clinical aspect, but also on the business aspect, on how they can develop these procedures and tests within their facility and how they can expand their practices and expertise. When we started this organization, Hands-On Diagnostics, in 2013, 10 years ago, actually, we surveyed across the country the entire physical therapy profession. 97% of physical therapists, they had no idea that the physical therapist is allowed by their practice act to perform EMGs and ultrasounds and all these tests to patients. And not only allowed to perform them, but also to bill insurance companies and get paid from insurance companies. At that time, only 3% of the PT industry knew about this. But these things have changed with campaigns and informational campaigns. Now, our practices are catching up. They're joining our organization and they are helping their patients more effectively and their bottom lines significantly. I will tell you that at this point, there are some even of the big organizations like Physical, like USPH, Court, and Select Medical, that some of their locations, they have already joined HODS and catching up with this new technology. Yeah, we definitely want you to consider joining our movement. We have a website, callwithhods.com, where you guys can go there, schedule an appointment to talk to us, and we can provide you with all of the details about the program, what it takes, and also projected successes that you can have from the application of the program. And
I would like to invite everyone to the 12th annual HODS Symposium, the HODS Symposium 2025. The symposium is entitled Primary Care Physical Therapy, Mastering Diagnostics, Manual Therapy, and Advanced Interventions. Master the science, apply the skill, and transform your practice. It's going to be a killer program. It's going to be pretty amazing. Thank you for joining me in today's episode of Your Practice, Your Money, where clinical success meets financial freedom. If you found value in today's episode, please remember to subscribe here or on Apple Podcasts, on Spotify or YouTube. And please leave us a review and share about our podcast to your friends and colleagues, because this can help more practice owners to add value to their practices and solve everyday problems. For more strategies, resources, and tools to help you grow both your clinical impact and your financial freedom, head over to www.yourpracticeyourmoney.com. Until next time, keep building the practice and the life you deserve. Take care.